Many of you maybe wanted to come to this conference for our keynote speaker, and he hardly needs an introduction and about his background, but he deserves our full welcome. We have the amazing privilege of hearing Dr. David Gershenson. He is definitely, no one would debate, an unparalleled authority in the field of low-grade serous ovarian cancer. He is at the University of Texas MD Anderson Cancer Center, as we all know. Dr. Gershenson is a professor of gynecologic oncology and reproductive medicine at MD Anderson. I just want you to know the amazing things that Dr. Gershenson has done. He served the chair of the department from 1988 to 2012. That's a long time to devote to being a chair, as well as a researcher and a clinician. His major focus is on clinical and translational research of the rare ovarian cancers. In the past 4 decades, he has concentrated his research on the study of serous borderline tumors as well as low-grade serous ovarian cancer. His profound insights in LGSOC are the result of extensive clinical and translational research, making him what we all know is the foremost authority in the field. Dr. Gershenson's impact on LGSOC to all of us is immeasurable, right? He is what we think of when we think of LGSOC. He served as editor-in-chief, listen to this one. He served as editor-in-chief of it's an amazing journal, Gynecologic Oncology, for 18 years. And he continues to contribute as editor emeritus now. It gives me great pleasure to give a grand welcome to Dr. David Gershenson.
Wow. Good morning. And thank you, Nicole, for that kind introduction. I appreciate it. I wish I could live up to it. Well, it's a real honor to be here, and I want to thank the STAAR board for giving me the opportunity to speak to you today. In case you didn't know it, it's much more intimidating for us as physicians to talk to a room full of patients rather than a room full of doctors. So that you may not know that, but it's true. So these are my disclosures. So almost everything we've learned in the last couple of decades about low-grade serous ovarian cancer is attributable to you as patients, whether you have been enrolled in a clinical trial or simply received standard of care. Almost all of it would not be possible if it weren't for you. And I think that's something that you need to clearly understand, and it's not said enough in terms of how much we know. You know, most doctors only see a very few patients with this rare ovarian cancer, and therefore they may not be able to completely understand all of the nuances associated with it. And that's why it's so important that many of the experts that will be speaking to you at this conference are really focused on this rare cancer. So we've learned a lot in the last couple of decades, as I mentioned. We've learned from preclinical or laboratory-based studies, translational research studies. Probably we've learned the most about how to care for women with low-grade serous ovarian cancer through simply observational studies. So these are retrospective studies of the experience with treating this rare type. And these may come from case reports, large institutional experiences like MD Anderson, Memorial Sloan Kettering, and other places, national databases, and rare tumor registries. And then, of course, in the last, I would say, 15 years, we've begun to learn a lot through clinical trial enrollment. and I think we've made a lot of progress. But the early progress that was made was just from retrospective studies and the experience that many of us had. So the first decade of this 21st century was really an inflection point in our understanding of low-grade serous ovarian cancer. In 2003, the Human Genome Project was almost complete, and we were beginning to learn a lot about the alterations or mutations or amplifications that occurred in all types of malignancies. In 2004, after almost 15 years of experience, the MD Anderson Group introduced the binary grading system for serous ovarian cancer, and it was separated into high-grade serous ovarian cancer, the most common subtype, and low-grade serous ovarian cancer. Prior to 2004, there were 2 3-tier grading systems. It was very confusing. We didn't really understand it. There was no consensus about it. So this really clarified, I think, for the world how to classify. But it took another decade before the WHO accepted this and adopted it into their classification system. And then a year later, in 2005, the Gynecologic Oncology Group established the Rare Tumor Committee. I had the honor of being the chair of that committee for several years, and we began to develop clinical trials for rare tumors. Prior to that time, for decades, patients who had rare tumors, clear cell carcinoma, low-grade serous carcinoma, mucinous carcinoma, were in clinical trials for ovarian cancer, and they constituted probably less than 5% of the patients enrolled in those trials. Therefore, we were able to learn very little about the biology, about the clinical course of women who had this rare subtype. And then in 2007, the Rare Tumor Committee activated its first clinical trial, which happened to be a trial for low-grade serous ovarian cancer. This is the binary grading system. I won't spend a lot of time on this, but the primary feature is nuclear atypia that divides high-grade serous from low-grade serous, and then there's a secondary feature of the number of mitoses per 10 high-power fields. And again, this really helped clarify how to distinguish these 2 subgroups. So I decided for the format this morning that I would ask about 12 different questions. Now these probably, you have other questions, I know, but these are at least 12 questions that I thought would be of interest to the group. And the first question is, what is the relationship of serous borderline tumor to low-grade serous ovarian cancer, which is a common question. So we do believe that serous borderline tumor is a precursor to the development of low-grade serous ovarian cancers, and although we don't know it, it's possible that every woman who develops low-grade serous ovarian cancer did initially have a serous borderline tumor. The risk factors for serous borderline tumor are infertility and hormone replacement therapy, taking estrogen. There's a question about whether fertility drugs also increase the risk of a serous borderline tumor, but that's not been validated. For stage 1 serous borderline tumors confined to the ovary, the treatment is very simple. It's surgery alone, and the cure rate is over 99%. However, for stage 2, 3, and 4, serous borderline tumor, and this means that there are implants within the peritoneal cavity, in the omentum or in the peritoneal lining, that are usually non-invasive. Surgery alone is still the treatment. However, if the peritoneal implants include what's called invasive, or used to be called invasive peritoneal implants, and now is synonymous with low-grade serous carcinoma, then in addition to surgery, obviously postoperative therapy is necessary. We also know that about 20% of women who are diagnosed with low-grade serous carcinoma have a prior history of serous borderline tumor. And at the time of diagnosis of low-grade serous ovarian cancer, about 60% also have areas of serous borderline tumors. So there's a very, very tight relationship between these two entities. This is, on the left, you can see a gross photograph of a specimen, the uterus with the two ovaries with these excrescences, and on the right is a photomicrograph of what it looks like. So these are non-invasive. They don't invade into the surrounding tissue. They're sort of on the surface. They can also be on the internal surface of the ovary. And then these are the peritoneal, these are what the peritoneal implants look like. On the left is a non-invasive peritoneal implant. It's very circumscribed. It's pushing the border, but it's not invading into the surrounding tissue. And on the right is an invasive implant, or low-grade serous carcinoma, that is actually invading into the surrounding tissue. Second question is, what's the mechanism of the pathogenesis of low-grade serous ovarian cancer? Well, the simple answer is we don't know what causes this. We have certainly found many clues over the last couple decades. One of them is that we know that 95% of low-grade serous ovarian cancers are associated with a positive estrogen receptor, about 50% with a positive progesterone receptor. And that's very important, as you know, and I'll talk about in a few minutes. And then on the right is the MAP kinase signaling pathway, which is the molecular pathway that is very common. It occurs, alterations in this pathway occur in a little over 50% of women who have low-grade serous ovarian cancer. We don't really understand what's going on so much in the other 50% or so, but this pathway could also be playing some role that we don't yet understand for those women as well. So there were 3 studies published in 2022 and 2023, all of which did genomic profiling, or what we call somatic tumor testing, on specimens from women with low-grade serous ovarian cancer. And again, you can see in that middle column, MAP kinase mutated, a little over 50% in each one of the 3 studies were mutated with, it's usually either KRAS, BRAF, or NRAS mutations. And then you can see the numbers, the percentages non-MAP kinase mutated. And we learned from those 3 studies that women who had a MAP kinase alteration tended to have a somewhat better prognosis, but it's not all or none, and certainly prognostic factors apply to groups of women, not in individuals. So even women who have no favorable prognostic factors may do very well and may be cured. But we did see this trend in that. This is our study from MD Anderson, in which we profiled 215 women with low-grade serous ovarian cancer. And the women with the MAP kinase mutated tumors had a better overall survival compared to those without. We also saw an association with age, and we saw that younger women had a lower frequency of MAP kinase mutated changes, alterations, and older women had a greater frequency. And these are the mutations we found in that study. It's hard to read this, but the most common mutation in these 215 women was KRAS. 71 women had KRAS, and then about fewer women had NRAS or BRAF, and then it trailed off to a whole series of other alterations or gene mutations. The third question I'm asking is, what is the primary treatment for low-grade serous carcinoma? And everybody in this room, I think, understands that, but just to review it, primary surgery is the preferred approach. Usually that's based on a diagnosis of an ovarian or ovarian masses on ultrasound. The CT, CA-125 is elevated. And it's important, if a woman has those features, that she be referred to a gynecologic oncologist. Over the course of my career, I've seen too many women who've been operated on by an obstetrician gynecologist thinking they had a benign mass, only to find low-grade serous carcinoma at the time of surgery. And what that translated into for many of these women was they had to undergo 2 or 3 surgeries when this all could have been done with 1 surgery. And so I think these criteria for referral from an obstetrician gynecologist to a gynecologic oncologist need to be refined, but certainly in practice they're far from perfect. The surgical procedure is if the disease seems to be confined to the ovary once the surgeon gets into the abdomen, is a hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and multiple biopsies and cytologies. That's in patients who seemingly have it confined to the ovary. But if a patient is young and has not completed childbearing, there are patients, unfortunately not as many as we would like, but there definitely are women who may have fertility-sparing surgery and have preservation of the uterus, 1 ovary, or at least part of 1 ovary. A number of our patients now, following their primary surgery with preservation of the uterus and ovary, for instance, are still undergoing oocyte retrieval and cryopreservation, just in case. But of course, if the tumor is metastatic, and that's usually very obvious at the time of primary surgery, then the goal is maximum cytoreductive surgery to achieve what we call no gross residual disease. So no, at the end of the surgery, the completion of the surgery, there's nothing that is either seen or palpable. However, we understand that that doesn't mean that there are not microscopic cells there. There always are going to be microscopic residuals, and so that's, of course, the reason for postoperative therapy. This is a table of multiple studies on primary surgery for low-grade serous ovarian cancer, and as you can see in that median progression-free survival column, that women who have no gross residual do have a better progression-free survival, and likewise in the right-hand column, a better overall survival if they're able to achieve that. But again, this is not perfect, and there are many exceptions to this rule. Question 4, what are the important considerations following surgery for low-grade serous ovarian cancer? So one question is, should I request a second opinion on the pathology? Because we see many patients referred to us with high-grade serous carcinoma only to find out when we review it, it's low-grade serous carcinoma, or they're diagnosed with low-grade serous carcinoma, our pathologist diagnosed only serous borderline tumor. So a second opinion on the pathology is really important, I think, for rare tumors. Should I seek a second opinion regarding postoperative management? Many women choose to do that. Again, it depends on if you're seeing somebody who's already pretty expert, then that may well not be necessary, but that's obviously a personal choice. It's a good idea to have a baseline imaging study following surgery to know what the baseline is. Even though the surgeon may have thought, the gynecologic oncologist may have thought they removed everything, a baseline CT may show a few areas. We always recommend at the time of diagnosis now genetic testing mainly for the BRCA gene, and again, only about 2 to 4% of women with low-grade serous ovarian cancer have a germline BRCA mutation, so it's not really part of the ovarian breast cancer hereditary situation. We also recommend somatic tumor testing. And this is for future reference. It doesn't affect our primary treatments right now, although it may in the future, but it really is for future reference, particularly if a woman does develop recurrence in terms of selecting what may be the best therapy. And regardless of the postoperative treatment, monitoring is really always recommended, and the standard pretty much is in year 1 to have imaging and a CA-125 every 3 months, and then gradually less frequently. In year 2, every 4 months, years 3 through 5, every 6 months, and then once a year after 5 years. But that also varies a little bit from center to center. Question number 5, is there a role for neoadjuvant chemotherapy in low-grade serous carcinoma? This is giving systemic treatment prior to surgery. It's not a preferred approach. The reason it's not a preferred approach is because cytotoxic chemotherapy is, as you know, not as effective for low-grade serous carcinoma as it is for the more aggressive types. It doesn't mean that it can't be effective, though. There are women who respond, and I'll show you that in a minute. However, there are a small proportion of patients who have disease in the liver, in the vagina, in areas that cannot be removed at the time of primary surgery. And so the concept there is to shrink these areas prior to an interval cytoreductive surgery. This decision should always be made by a gynecologic oncologist, but there are no absolute criteria. The only criteria we really have are imaging studies to look at where the distribution of the tumor sites, and also we have laparoscopic assessment, which can allow us to decide whether to proceed with the cytoreductive surgery or not. Usually neoadjuvant treatment consists of 3 to 6 cycles, followed by interval surgery, as I mentioned. And there are 2 studies recently reported that's actually showing that in the United States, the frequency of neoadjuvant treatment for low-grade serous carcinoma is increasing, and that's exactly opposite to the trend we would hope for. So that needs to be reversed in some way. This study by Dr. Cobb on 36 women with low-grade serous carcinoma compared to 36 women with high-grade serous carcinoma showed us that the response rate to paclitaxel carboplatin was only 11%. It was 75% for high-grade serous ovarian cancer. So again, in this setting at least, chemotherapy was not very effective. It is more effective in some other studies, though. That led us a few years ago to say, look, chemotherapy is really, we're going in the wrong direction. And so we decided to do a pilot study using Fulvestrant, which is an anti-estrogen degrader. It's an intramuscular drug combined with what's called a CDK4/6 inhibitor. CDK4/6 inhibitors affect the cell cycle. They are FDA approved for breast cancer. And when you combine them in breast cancer with endocrine therapies, they're much more effective. And so we did this in women who we thought were not suitable for primary cytoreductive surgery in a pilot trial of 15 women with low-grade serous carcinoma. On the left, you can see the results I showed you a minute ago from Dr. Cobb with an 11% response rate to chemotherapy. And on the right are the results of the pilot study showing us that 60% of the women in the pilot study treated with fulvestrant and abemaciclib, which is the CDK4/6 inhibitor, responded to therapy. So certainly some advance in this area, and there'll be further studies. There's actually another study for neoadjuvant treatment using the Verastem drugs, avutometinib and defactinib. What's the best adjuvant postoperative therapy? Well, this is the NCCN guidelines that are the latest guidelines that just came out, but although they haven't changed much. And for stage 1A, confined to the ovary, or 1B, confined to both ovaries, it's observations, the postoperative management. For stage 2, 3, and 4, the options are either chemotherapy followed by usually letrozole maintenance therapy, or at least an aromatase inhibitor, versus just an aromatase inhibitor, either letrozole or anastrozole, without prior chemotherapy. Right now, we don't know which is better, and I'll show you the clinical trial that's ongoing. The real conundrum is with stage 1C. Look, the three options: observation, systemic chemotherapy, or hormonal therapy. What does that tell you? It tells you simply we have no idea what the best treatment right now is for women who have stage 1C, which means positive cytology, tumor on the surface of the ovary, or rupture of the ovary at the time of surgery. So that's a question that needs to be answered. Again, we know that low-grade serous carcinoma is relatively, not completely, relatively chemo-resistant. But you can see in that first study from a German cooperative group, Grabowski, 23% of women in that study responded to chemotherapy with low-grade serous ovarian cancer. But in some of the other studies, it's less. And certainly in the recurrent setting, it's probably no higher than 15% with treatment with chemotherapy, but it's not zero. And some patients do have stable disease for sometimes many, many months or even years. And we know that prior to about 2015, women who had primary surgery for low-grade serous carcinoma, all of them received chemotherapy because that's all we really knew about. But our group around 2015 began to study this, and we knew that some of our patients, after they completed chemotherapy, were also receiving maintenance therapy with hormonal therapy. It could have been aromatase inhibitor like letrozole, tamoxifen, depolupron, other hormonal agents. And we found that when we compared those women who had the maintenance with the hormonal therapy to those women who had only surgery plus chemotherapy, they had a much better progression-free survival. And so that gave us a clue that those women were doing better. Also around the same time, the Johns Hopkins group reported on 27 women who had primary cytoreductive surgery, stage 2, 3, and 4 low-grade serous ovarian cancer, and they went straight to hormonal therapy. Most of them aromatase inhibitors, although not all. And the results were pretty comparable, although it was a smaller study and they didn't have as long follow-up as in the MD Anderson study. But that really led us to deciding to mount this clinical trial a few years ago, NRG GY019. This trial is ongoing. It's for 450 women, and already about 420 women have been accrued to this study. So it's going to be complete sometime later this year. It'll take a while to look at the results. But following primary cytoreductive surgery, these 450 women are randomized to either paclitaxel carboplatin chemotherapy for 6 cycles, followed by letrozole maintenance therapy indefinitely, or until disease progression, versus just letrozole without prior chemotherapy. And right now, Amanda Fader is the principal investigator. I'm the co-principal investigator. Neither one of us has any idea which one of these two treatments. Are they equivalent? Is one better than the other? There has been an interim analysis a little over a year ago that showed no difference at that point. They're going to do another interim analysis in July, and the study will probably be almost complete. But unless that shows a difference, they'll need to follow those women longer to see if we can figure out which one of these treatments is better. But this is a very important study, and once that's completed, there will be other treatments like MEK inhibitors that move into clinical trials at first diagnosis. Question number 7, should all patients with newly diagnosed low-grade serous carcinoma be given information about prognosis? I think the answer is, from my experience, no. Not everybody wants to know about prognosis, especially at the time of their diagnosis. So that's a very personal decision. I've talked a little bit about some of the factors already. The next slide shows the factors we know about If you're not interested, close your eyes for a couple minutes. I won't say anything. But look at on the left-hand slide of the slide are the prognostic factors, favorable prognostic factors we know of. On the right-hand side are maybes. These have emerged out of maybe one study, but have not been validated enough to know if they really are solid prognostic factors. But again, remember, prognostic factors apply to an aggregate of women. They don't necessarily have any influence on an individual, and there are many exceptions even if you have none of these prognostic factors. We reported a year or so ago this study. We think we're making progress using, we're doing that clinical trial comparing letrozole with chemotherapy letrozole. But in the meantime, there are many women who choose not to be on a clinical trial like that. They don't like the randomization part. And so we've treated them at MD Anderson with one of those two strategies following primary surgery. And a couple years ago, we reported on 99 women with stage 2, 3, or 4 low-grade serous carcinoma. At the time of the report, fewer than half of the patients had recurred, and 50 of the patients were relapse-free, and we think that that's showing us that with good contemporary treatment, that we are going to increase the cure rate, and we are going to have a lower relapse rate than the 70 to 80% that was reported a few years ago. So we need to follow these women longer and a larger group of these women because we are treating more now. But this, I think, is encouraging news, and I hope it drops to even less than 50%. The next question is, how long should a patient take letrozole? Well, unfortunately, the current recommendation is indefinitely, possibly for the rest of your life, or of course until disease progression. If disease progression occurs on letrozole, then there's a change in therapy. But we also know, and you know very well, that the side effects from letrozole or anastrozole are not trivial. And they include vasomotor symptoms, night sweats, sleep disturbance, mood changes, joint pains in 15%, vaginal dryness, osteopenia, and osteoporosis. The recommendations for women on letrozole should include a baseline DEXA bone scan and then annually. Usually we recommend supplemental calcium, vitamin D. And if somebody does have a joint pain, sometimes we can ameliorate that with switching to anastrozole, which we think is just as effective as letrozole. Or sometimes patients need anti-inflammatory drugs, and there are some patients who just cannot tolerate aromatase inhibitors and they have to stop. Hopefully in the next few years, we will be able to say that if you're without evidence of disease and you're at 10 years following your diagnosis, you should be able to stop letrozole altogether. But we don't know that yet. In breast cancer, even in early breast cancer, most experts are recommending 10 years of an aromatase inhibitor. But I'm hoping that at some point we'll have enough experience to understand that we can limit the use of this drug and you don't have to take it for the rest of your life. Again, you're very familiar with these side effects of aromatase inhibitors, and these are some of the drugs that are used to treat those side effects. Veoza has been a miracle drug, I think, for vasomotor symptoms or hot flashes. Unfortunately, it's very expensive, and not all insurance plans will approve it, but it's really, apparently, from what we understand, a wonder drug. But these are some of the medications that can be used to help with some of the side effects, but they're far from perfect. Next question is, what's the treatment for recurrent low-grade serous carcinoma? Well, there are several options. Secondary surgery may be recommended. Systemic therapies, chemotherapy, endocrine therapy, targeted therapies, I'll talk briefly about. Immunotherapy, let me say a couple things about immunotherapy. All of the molecular profiles of women with low-grade serous carcinoma suggest that immunotherapy is not going to be very helpful. In ovarian cancer in general, it's been very disappointing, although there are some patients who do benefit from it. But in low-grade serous carcinoma, I would say we don't have enough experience yet, but it doesn't really look like, at least the current immunotherapies, immune checkpoint inhibitors are going to be effective. That doesn't mean that other newer immunotherapies may not be effective. Rarely we use radiotherapy in very selective patients, maybe to spot treat a lymph node enlargement or a bone involvement or something like that, but very sparingly. But we also know that for treatment of recurrence, there's no standard sequencing of these various systemic treatments. We try to explain what the treatment options are, compare the risks and benefits of all the drugs, and all of these drugs, of course, have side effects, and have the patient make the best decision she can with physician guidance. Of course, clinical trials are always encouraged, but some patients, as I already mentioned, don't like to participate, particularly if it's a randomized clinical trial. Secondary surgery is applicable for some women who have a recurrence, particularly their first recurrence, but there's no prospective data. It's all retrospective data. The one on the left is from our group at MD Anderson. And we know if a woman undergoes secondary surgery and you're able to remove all of the disease you can see or feel, they're going to do better than if you can't remove it. But the selectivity of recommending secondary surgery is really for women who have maybe one or at the most 2 or 3 sites. It's not really generally recommended for like carcinomatosis with multiple small implants spread throughout the abdomen. These are the chemotherapy and endocrine therapy drugs that we have available for the treatment of recurrent low-grade serous carcinoma. I'm sure many of you have had some or a lot of these drugs. I mentioned about the CDK4/6 inhibitor. Again, it's FDA approved for breast cancer, but not for ovarian cancer right now, although that will change in the future. But they're very hard to get. Most insurance plans will not approve them, although some do, combining them with one of the endocrine therapy options. We did learn, I think, only a few years ago that tamoxifen, which is another endocrine therapy, is not as effective in general as the aromatase inhibitors. This is from both retrospective and prospective studies. The response rates to tamoxifen were lower than with the aromatase inhibitors. That doesn't mean that some women may not benefit from tamoxifen, though, because there are some who do. But we know it's less effective in general than the aromatase inhibitors. This is GOG 3026 that was reported at the SGO meeting a couple years ago, and we're preparing a manuscript. And again, this is for women who had recurrent low-grade serous carcinoma, 51 or 2 women who were treated with letrozole. They had not previously had letrozole, and they were given also ribociclib, which is a CDK4/6 inhibitor, and in our updated data, the response rate is over 30%. So this did look like some advance in the treatment of recurrent ovarian cancer, low-grade serous ovarian cancer, and I think will become eventually, at least on the NCCN compendium, and be widely available for treatment of recurrence. You can also combine ribociclib with another endocrine therapy like Fulvestrant. And this just shows, this is a waterfall plot that shows how many patients actually had some response, even though it might not have been an official partial response. Then there are the MEK inhibitor studies. The first study was with selumetinib from the GOG, 15% response rate. Then there were two second-generation MEK inhibitor studies, the Milo study, which compared benimetinib, a MEK inhibitor, to physician's choice chemotherapy. This study was a negative study and closed early because it crossed the futility boundary. And benimetinib is a reasonably effective drug, but the way they designed the study with the statistical design, it looks like the women on the physician's choice arm of the study actually performed better than they thought. And that accounted for no difference in progression-free survival between the two arms of this study. Then the GOG 281 study, 260 patients, recurrent low-grade serous ovarian cancer, compared, in this study, trametinib, or Mekinist, to standard of care, and one of 5 drugs, not all together. Patients on the standard of care arm got one of those 5 drugs. And this was a positive study. It was the first positive randomized phase 3 trial in low-grade serous ovarian cancer. Nevertheless, Novartis, the company that makes trametinib, made a decision not to go for FDA approval, which I think was it shows you the challenges we have in studying rare tumors. It was financially not in their best interest to do so, even though we pushed them to do it. However, it did end up on the NCCN compendium, and now, at least in the United States, most all women, if they want to have trametinib, can receive it. But that just goes to show you the problems. This is the RAMP 201 study, the phase 2 study with avutometinib and defactinib, that also showed a good response rate, maybe as high as 60% in those women who had a KRAS mutation. And now, of course, that's transformed into the phase 3 randomized study, RAMP 301, in which patients are randomized to either standard of care, which is one of the drugs you can see, liposomal doxorubicin, paclitaxel, letrozole, or anastrozole, or to the avutometinib and defactinib. This study's ongoing. We just opened it at MD Anderson and already we're about to put 6 patients on the trial. But it's a good study, and whether that combination is actually going to be better than some of the other drugs, we don't know yet. Oops, excuse me, it may be, but we need to find out. And that, if it is, you may see that combination move into frontline trials as primary treatment compared to one of the 2 options that are in the GY019 trial. We know that women who have a BRAF V600E mutation and with low-grade serous carcinoma, and that's about 10%, are also candidates for the FDA-approved combination of dabrafenib, which is a BRAF inhibitor, and trametinib. And so we've treated a few patients with that combination. And then most recently in 2022, the FDA approved Mirvetuximab, or Elahere, for recurrent ovarian cancer. All of the trials were done with high-grade serous ovarian cancer, but once it was approved, we knew that women who had recurrent low-grade serous carcinoma could be potentially eligible for this drug if their folate receptor assay was positive, positive meaning at least 75% positive. And so this is yet another option for women. We know that about 25 to 40% of women with a low-grade serous ovarian cancer, their tumor will have a positive folate receptor assay. We don't have yet enough experience with the drug in low-grade serous carcinoma to know how effective it's going to be. I already have one patient who is responding very well to this drug, but it's yet to be seen how effective it will be. But it is another option. These are some of the ongoing studies with PI3 kinase inhibitors and letrozole. CDK4/6 inhibitors, and hormonal drugs. Some of these trials include immunotherapy, and so on. What about other needs? Certainly, a lot of patients are interested in supplements. They want to know, is there a magic diet? Things like that. We don't know the answer to any of those things, but I always recommend seeing an integrative medicine specialist who tend to be the experts in this field. Also, there's a website on Memorial Sloan Kettering that www.mskcc.org/herbs that has a lot of information about supplements. Obviously, pain control is important, as well as palliative care for some patients. But we need to be very cognizant of the other needs other than just treatment. And then finally, what are some of the future directions? Well, I think one thing that we absolutely need to do, and we started to do but can do much better, is for physicians and scientists to partner with groups like STAAR, with groups like Jane Ludeman's group in New Zealand, to advocate for women with this rare tumor, to advocate with the FDA, to advocate with pharma, giving you the example of Novartis not wanting to approve trametinib. We really need to do a much better job of that. So that's one, I think, initiative. The other initiative is a few years ago, Jane Ludeman and her family provided funds to support initiatives in the study of low-grade serous ovarian cancer, and we organized this international consortium that now includes 28 physicians, scientists, and patient advocates. And we meet monthly. We have subcommittees. We have 3 major projects. I'll just tell you very briefly. One of them is a major deep dive into the molecular biology of low-grade serous carcinoma called the Luminate study, and that's in development and will be starting up very soon. It's in the planning stage, and it's to look at the specimens from low-grade serous carcinoma and to put them through many different assays, including some very new assays, to see if we can find new clues on how to treat this rare tumor. A second project is with the Ovarian Cancer Research Alliance. We're in discussion with them to create a rare tumor registry for women with low-grade serous ovarian cancer. And this would include 3 subgroups: those women who are newly diagnosed, women with recurrence, or women who have undergone fertility-sparing surgery. This will be a retrospective database that will allow us to really learn a lot more internationally, because these patients will come from 7 different countries or more: New Zealand, Australia, Canada, France, UK, United States, Italy, et cetera. So this is in the works and should, I hope, be finalized very soon. And then the third major project is a collaboration with the Global Coalition for Adaptive Research, in which we are trying to develop a platform trial, which we hope will be active later this year. This platform trial includes both phase 2 and phase 3 trials, some of them randomized, that can be going on simultaneously. So we may have 2 or 3 phase 2 trials for low-grade serous carcinoma that are ongoing. We may have a phase 3 randomized trial. We already have 2 companies who are very interested in studying their drugs for low-grade serous ovarian cancer. This will be strictly for women with recurrence. And so this is really an exciting initiative that we're doing as well. So let me finish there, and again, thank all the patients and their families. It's great to see all the significant others here with you today, and also acknowledge all of the support we've received from not only STAAR Ovarian Cancer, but from several other groups. So thank you very much for your attention.
Thank you, Dr. Gershenson. Dr. Gershenson, can we see if anyone has any questions?
Yeah, sure, I'm happy to try to answer any.
Does anyone, I know your brains are probably like, wow, that was a lot. Here we have a question from our friend Sarah.
Thank you so much for being here, Dr. Gershenson. So looking towards the future, there are, at least for me, I've never been NED. I've always been in some sort of treatment. And so looking at people who are either newly diagnosed or in the recurrent phase doesn't capture people like me. How do we advocate for ourselves to make sure that we are included in these groups?
Included in?
When you were talking about the future, my brain already, Letrozole. You were talking in the last slide about the three different groups that the OCRA group was looking at.
Yes, okay. Yeah, so the way that will work in effect will be the institutions who represent the ICLC, that international group that comes from 7 countries. The patients in that registry will come from those institutions that are involved right now in the ICLC, if I'm understanding your question. So it won't be, if you're being treated at another institution that's not part of the ICLC, you probably won't be in that database. Now, we're still going to learn about women with recurrence or new diagnosis. Does that answer your question?
Maybe I'm not being clear, or maybe I'm remembering the slide incorrectly. OCRA is going to do is it retrospective?
A tumor registry.
The tumor registry.
Right.
And they're going to have newly diagnosed, recurrent, and then women who, fertility specialists.
Yes.
How do people who have never been NED and would never consider being in a recurrent context, how will we be counted in that? Registered.
Well, out of
how
that
will you be registered in that?
Out of that registry will come publications based on the study of all those women. But again, if you're asking if you're being treated somewhere else and not in one of the institutions in the ICLC, you likely will not be part of the registry, if that's what you're asking.
Yeah, I think she's saying is there a way that you're not in one of those? Can you be included? Is there a way to get included?
Right now, at least right now, no. But that may change in the future. You know, we are going to add other members to the ICLC also. We've added a number of new institutions, some new countries, Italy. So there may be an opportunity, but right now, no, if I'm understanding the question.
Yeah. I think also she was curious in terms of if you'd never been NED before, but there'll be some women who've never been NED before who'll be included within that from when they were newly diagnosed or had progressive disease as well in the samples. That's correct, isn't it?
From those institutions.
The question is mostly to advocate for those of us who may not fit those 3 criteria.
Yeah. Well, again, this hasn't even started yet. It will expand. And again, low-grade serous carcinoma is one of 2 rare tumors that are in the first wave of this registry. So once it starts, it will change over time. But we're also at the OCRA is going to determine a lot of what we're able to do in terms of the funding for this initiative.
All right, other questions? Okay, Rachel up front, and then.
So you mentioned treminative for recurrent with BRAF mutations, and Novartis not wanting to take that on. So if how would we get that drug? Like how does that happen if, you're saying they didn't want to produce it and such? So how does that come to market? Or if we have recurrent with the BRAF, like how does that happen to get that drug?
So trametinib has been on the market commercially for several years. It was initially FDA approved for melanoma, so it's been there. So if a drug is not FDA approved, you can still get access to it. What has to happen, it has to become part of the NCCN compendium. How does it do that? You have to have a publication, at least one publication, that shows the benefit of that drug. And so our phase 3 randomized trial that was the first positive trial, and really the only positive trial so far, in low-grade serous carcinoma, allowed us to be able to get this drug on the NCCN compendium. So it's available. I've not had any patients in my practice who've had a problem getting access to it. It's there. But it's just, it's kind of a roundabout way. It would have been better if it was FDA approved. The other thing that did, because it was not FDA approved, is in many other countries, women don't have access to it. It's not nearly as easy in Europe, even, to get access to that drug. So, but it is a roundabout way. And the same thing will be true once we publish the paper, which I hope will be in the next few months, on the CDK4/6 inhibitors. That will get on the NCCN compendium, and women will should have full access to that. But right now they don't.
Guy, so if we were told that drug would be helpful like a few years back, and we recur, we could still have access to that.
Yes.
Great.
Yes.
Cool. Thank you.
Dr. Gershenson, I think it would be helpful, I'm sorry, that was a little loud, to explain the FDA approval of a drug for a specific disease versus what it means to be on the NCCN guidelines for a patient.
Well, again, usually you have to have, usually they require a phase 2 study that shows benefit, and then they further require a phase 3 study where it has to be randomized against standard of care, whatever that is at the time, in order to become FDA approved. And of course, for common cancers, breast cancer, colorectal cancer, prostate cancer, it's easy because they have thousands of patients and they have all kinds of drugs that are approved every year. Not so easy with a rare tumor, so it's a much slower process. But again, as I illustrated, even when we do have a home run, drug companies don't have much incentive to approve it, and that's usually related to financial reasons. And that's why advocates like yourselves can be so important in changing that paradigm.
All right, we have a question here.
So she said there were tears, and I already had some. So my frustration is there are so many of the symptoms that mimic menopause. So for example, I'm a teacher, and there are several teachers right now who are perimenopausal, menopausal, and I just feel like every time they say they're bloated, all of those symptoms, I want to say, just get a scan, because there's nothing, like a mammogram. So what does the future look like with research or whatever as far as something like a mammogram that's for ovarian cancer?
You're talking about early detection?
Early detection,
Yeah.
yes. Because a lot of times, as you know, it's detected too late or later. So
Well, there have been a few very, very large studies of thousands of women using CA-125 and ultrasound for early detection of ovarian cancer. They have basically failed. Right now, we do not have an early detection for ovarian cancer. There are many smaller studies working on this problem, though. Lavage of the vaginal canal or the uterus to try to collect cells, things like that, different imaging studies, things like that. So I think at some point we will, but right now, there is no effective screening for ovarian cancer, period, if that's your question.
So would you not recommend that someone who is having those symptoms to get the C125? Because I kind of read pros and cons of that and a
Someone
scan.
who's having symptoms?
Yeah, just
Yeah,
so
yeah.
they might
Well,
think it's,
well, if they're having symptoms, yes, absolutely, you should see your doctor, and, you know, if you still have your ovaries, an ultrasound, if you're having abdominal pain is one of the primary symptoms, bloating, urinary frequency, things like that, yes, you absolutely should have a ultrasound and a CA-125, sometimes a CT scan. Yes, absolutely. But when we're talking about early detection, we're talking about women who are asymptomatic. Yeah. It's very different.
So in reference to what we just talked about, before I got diagnosed, my gynecologist told me when I was worried about my 75 CA-125, she was like, it's probably nothing, you know, you're too young for cancer. Those were her words, and I was 39. And she, I just want to say, what can I tell other people to advocate for themselves? What are the magic words that you tell to a provider without, you know, sounding like, you know, you're trying to tell them how to do their job, but you're like, nah, I don't feel good about it.
Well, of course, in a referral center like MD Anderson or other large referral centers, we see many patients who've not been optimally managed by their doctors. They've ignored their symptoms. They've ignored their test results, or the test results were not noticed. They've been misdiagnosed, you know. So we see a lot of that, and it just goes to show you that there are problems in the medical community. And again, particularly if you're going to your primary care physician, they may not even be that knowledgeable about ovarian cancer in general, much less low-grade serous ovarian cancer, and may not order the right tests. But that's why you really have to advocate for yourself, and that's why if there's any question and you feel uncomfortable about it, you should get a second opinion. And that's, you know, in today's world, that's not so easy. You want to get an appointment with a doctor, yes, you can have one in 8 months. You know, it's crazy out there right now, and we have the same problems. If we want to get a consult for one of our patients, particularly if it's outside MD Anderson, the wait is incredible. So, but you got to really advocate for yourself, because you know, you need to trust your gut, and if you think something's going on, it may not be, but push it to the limit. Don't be satisfied with the first answer.
All right, I think we have time for another one over here. Thank you, Dr. Gershenson, for.
Okay, it's a totally different topic, so we can let the other one go. I also just want to say I've seen you twice, and I really appreciate your kind demeanor, your tone in which you address your patients, and I've always felt so safe with you, so thank you for that.
Thank you.
My question is there, my assumption is that the reason why low grade is chemo resistant is because the cells divide slower than typical cancer drugs are in our system. Is that an accurate assumption?
Yeah, I mean, I think that's the general thought. Again, we don't really truly understand it very well, but yes, we as physicians think that's the case, that the turnover is slower, it's more indolent, and then they're just not as sensitive because of that. But that's a theory. We may be wrong. We may find out different at some point.
Okay, thank you.
Mm-hmm.
All right, there are a few. Oh, here's one. Carrie has one. Okay.
Hi, I've had a lot of different kinds of treatments. My latest is cryoablations.
Is what?
My latest is cryoablations.
Yes.
So I just wanted to know what you thought of that, and how many can you have before, you know, there's too much scar tissue or inflammatory disease?
Yeah. Well, I'm not an expert in that area. We have our radiation oncologists are the ones that do it. We have employed it for some patients. Usually, it's been for an area that's not very easily surgically resectable or is not safe. For instance, I had a patient recently who had a solitary mass. That was the only mass she had in the gallbladder fossa, and we used cryoablation for that. So I think there is a usefulness for that technology. How many times? I think in the same place, I'm not sure. I don't know the answer to that. I would have to rely on the radiation oncologist. But it is effective and can be useful selectively in some patients, yes.
So when you're in Kansas and you're not close to MD Anderson, and
Can
so
you
you're
talk
working
up?
with-
I'm hard of
sorry.
hearing.
You're working with a gynoc who's not maybe specialized in low grade. What are the tests that you would recommend, like something that you would do on your patient immediately? I know genetic testing, genome testing, ERPR testing. You mentioned folate receptors,
Right.
which I have not
Yeah.
requested for her
We-
yet.
We now are recommending that as well. And
Okay.
that can be done. There's a separate assay for it that's also can be part of the CARES platform testing that a lot of physicians use. Yeah, but I think that's something I recommend. And again, remembering, it's not currently part of primary treatment.
Right.
It's for future reference, but it's better to do it at the time of initial diagnosis so you don't have to scramble around later if you
Right.
need that information. But yeah, folate, but those would be, genetic testing, somatic tumor testing, folate testing, and then the standard monitoring that would be important to follow the patient. Some physicians are not, doing monitoring at intervals that are optimal. They may be doing it at 6 months when they should be doing it at 3 months. You know, Signatera, I thought I would get a question about Signatera. How
That
many
was my
people
next
have?
question. That was actually my next question.
Okay, so briefly, we don't use Signatera routinely at our place yet. It's under study. We don't yet know if somebody has a positive, it measures, it's a blood test that measures mutations in the blood. And could it herald an early recurrence, or something like that? The problem is we don't even know if you do find it, there's anything you can do, that there's any intervention that really makes any difference. Maybe it doesn't matter if you find it 3 months prior to finding it on an imaging study. So the studies need to be done with Signatera. It may become useful, I think it could, but right now it's not something I think is ready for prime time. I know some of you, I'm sure, have had it. But I don't think we know yet what to do with it.
Okay.
That's the problem.
Okay. Excellent. Thank you.
Hey, Dr. Gershenson. It's good to see you. I have what is a really basic question. So I underwent chemo last year. When we talk about responsiveness to chemo,
Yes.
what does that mean? I mean, you do your 6 rounds and maybe your CA-125 goes down for a few months and maybe something shrink. What constitutes a response?
So a response is based not on CA-125. The official system that's used is called RECIST, R-E-C-I-S-T 1.1, and it's based only on imaging. And to have a partial response, the tumor implants have to shrink by at least 30%. Of course, a complete response would be you don't see anything on imaging; it's all gone. So those would be the 2 categories: partial response, and then stable disease would mean that it doesn't grow. it doesn't grow at least 20%. If it grows 20% or more, that's disease progression. But let's say it grows 5%, that would, or it doesn't grow at all, that's stable disease. And that's also a good thing. But those are it's based on imaging, and it's not, although of course we use CA-125 as a guide, it's, nothing's perfect. Even imaging's not perfect, CA-125. But the actual official categories of response are based only on imaging.
Quick follow-up. So how does time play into that? So in other words, is 6 months and you've only grown 5%, you're stable, a year, or how does time work into that? Just to decide if chemo is effective, I guess.
Yeah. Well, if somebody, let's say somebody's on Doxil, and they're having imaging and CA-125 every 3 months, and it's stable. Some patients may have stable disease for, as I said, several months or years. So it's all got to do with the interval of the imaging that you're undergoing. So that will obviously vary from one patient to another, if I'm understanding your question. So it's if you're on a clinical trial, it's a little different because you have to show that you have at least 30% reduction in the tumor implants you're measuring, and you have to confirm that in the next imaging study you have, which is typically, let's say, 3 months later. So then that's a response, and that may last 2 years, and it may last 6 months.
And if it only lasted, 6 months, would it still be considered effective, or?
Yeah, well, it would still be considered a response. It would still be considered effective, but that's why, if you really think about it, progression-free survival is a much better endpoint. So that means is how long are you going on a certain treatment before you develop progression? And so so does it matter if you have stable disease for a year on a drug and then you progress versus if you have a partial response on a drug and then you progress at a year? It really doesn't matter. So progression-free survival is a much more meaningful endpoint than response, honestly, as long as you have stable disease.
It's, okay, let me come here.
Hello again. Dr. Gershenson, my question is about what we talked about going on trials, and everybody here is going to probably have to consider that if they haven't already. And if your surgery was too far out of the window of acceptance for the sponsor, or if they didn't have any tissue left and it's required to get on the trial,
Yes.
you have to have a biopsy, right? So my concern is it safe to have a biopsy either abdominally or vaginally? Like if you poke it, does it spread? Is that a crazy question? But it's something that everybody would have to consider if they're going on a trial, right? Because they need
If I'm understanding your question, you're asking me if you have a biopsy, will that spread the tumor? Mm-hmm. We don't think so. We don't, because it's done with a needle or a core, and it's not exposed to the surrounding area, we think. So I don't think there's any hard evidence at all that it spreads a tumor. I know that some people think that, but at least as far as I'm aware, we don't have any information that it does spread the tumor.
And that would be abdominally or vaginally, it would
Yeah,
matter.
I think it doesn't really matter.
Thank you.
All right, are you okay with questions? I mean, we're over your time.
It's your time. I'm
Okay.
good.
I think we could ask
I don't wanna- I
questions.
don't wanna-
We're nonstop.
I don't want to be disrespectful to everybody else.
That's so kind of you. See, he is amazing, isn't he? He really is.
Hi, thank you for taking my call.
Hello.
Too much time on the phone at work. I had a unique situation, so it's a little specific to me, but I have a general question. So I had the unfortunate of being diagnosed with high grade and low grade,
Yes.
and for whatever reason, neither of my tumors typed out in a profile that made sense. So it went from the Boise Cancer Institute to Johns Hopkins to UCSF, and everyone's kind of like, we don't know, we don't know. At what point do you stop and go? Because the current thing after treatment, because I got both treatments, the chemo and letrozole, they're like, we're just going to wait till it comes back, and we'll tumor test that. And oh, by the way, you'll never be eligible for a clinical trial because you had both, and you'll just mess everything up.
Yeah, I got it. One of our...
Is that true?
Well, okay, so the part about clinical trials, if they know it, yeah, that's unfortunately true. You know, this is such an exquisitely rare thing. One of our brightest fellows, she is at this very moment working with us studying the high-grade, low-grade tumors. In our vast experience, because we get a lot of referrals and hundreds of women with low-grade serous ovarian cancer, we've identified 39 women like yourself who have high-grade, low-grade. Some of the times both elements are diagnosed at the time of initial diagnosis, but sometimes you may diagnose the low-grade part and then they recur and it's high-grade. So yes, getting back to what I think part of what you're asking, you may need to do if somebody recurs later and you already know that it's high-grade, low-grade, you need to biopsy it as best you can, although we know all tumors are heterogeneous. Biopsy it to know, is it the high-grade component, is it the low-grade component, and the treatments may, as you know, may be very different. Yeah, it's a very tough situation. I couldn't agree more.
And I was also told that sometimes low grade can actually mask as high grade or turn into high grade.
Well, so most of the cases, they're diagnosed at the same time, concomitantly. But yeah, some of the cases are what we call metachronous, meaning they were diagnosed with low grade and then later on they had high grade. Now, does that mean that at the time of the initial diagnosis, the pathologist simply missed the high grade component? Or does it actually mean that the low grade turned into high grade? Answer to that question, we don't know.
So given how rare it is, should I try to get under her care at this point or wait until it comes back?
Should you try to get under?
The care of that person who's looking at those.
Oh, the fellow I'm talking about? Yeah. No, I mean, no, not necessarily.
Okay.
No, I think, you're in good places. Again, at some point you may want to get another opinion, at our place or somewhere else. They've studied this a little bit at Memorial Sloan Kettering. There aren't very many places. There are like only about 5 publications in the world that have ever been written about this.
And
so
what
that
are
shows
your
you how rare it
thoughts
is.
on systemic metformin?
I'm sorry?
Just taking metformin prophylactically, given the fact that it kind of has this anti-cancer benefits?
Yeah, I think, I would say I view it as a supplement that a lot of women decide to do, and I'm not anti-metformin at all. I think we just don't have enough knowledge to know if it's helpful, but I think it's pretty harmless and not necessarily a bad idea, if that's what you're asking.
Hello. Hi. I'm another one that is kind of never been clear. I've never been an AD. I've rolled from one treatment into the other for years. At what point, if we run out of treatments, is it possible to revisit treatments from the past
Yeah, great question. Sometimes it is. Sometimes it's really very individual. But yes, sometimes it's okay to revisit treatments, or sometimes maybe combine 2 different drugs that weren't combined before. You can try all kinds of different things. We all know, that at some point, some patients, the best recommendation is no treatment. The side effects are going to be worse than the disease.
That was my next question.
And they're at a point where they've had everything, and it's better, pain control and palliative care is the best option. But no, you can sometimes, that gets to be a little bit in the creative, subjective part of it, the artistic part of being a physician, not so much the scientific part.
And I've had a lot of people that I've known that have they've taken a break from treatment, kind of
Yeah.
to cleanse, detox the body, and then start back. Is that something that, you've recommended or could see being beneficial?
Yeah, again, it's individual. As physicians, we tend not to recommend that too often, but I think we're too strict about that, quite frankly. I think we could give more breaks than we do. So I think that's something that we need to better educate ourselves on the safety. You always worry if you take a break, it's going to grow. That's the issue. But I think we could be less strict than we are.
Well, I can say that having been initially diagnosed in '04, there was only like 2 treatments then, and so as the years have gone by, primarily with a lot of your research, seems like when something has stopped working, well, something else has come around, so that's kind of what there's been so many advancements in the last
I mean, one good
few years.
example of, if you've had trametinib, on the RAMP trial, you can still be on that trial because but it has a RAF MEK inhibitor in it, the avutometinib. Even if you've had trametinib, you could be eligible for that trial. So that gives you an example of, you've already been treated with a MEK inhibitor, but you are eligible. So we'll see more of that than we already have. But
Yeah, I know there's still a couple of more out there. I was just looking to the future, just curious.
yes.
Thank you.
All right. Can I get your neighbor first, and then you, Cecily?
Just a couple of quick questions.
Yeah.
You talked briefly about follow-ups, like with CA-125, all of that. What are your recommendations as far as follow-up with that, CT scans, et cetera? For example, I'm 6 years out. Are you recommending like once a year still, or is there ever a time where we just stop?
Yeah, great question. Answer is we don't know for sure. I think right now, it depends a little bit on, again, individualizing it. If somebody has early stage low-grade serous carcinoma, they're 5 or 6 years out, they're doing great, I would start to back off even annual scans. But if you had stage 3, at least right now, based on everything we know, I would do them. But
Okay, I'm stage 3, so.
yeah, on that one study I showed you of the 99 women, 49 of whom had recurred, but 50 had not. We're starting to see a trend, and it's too early to tell, but it looks like if you haven't, if women have not recurred by about 6 years, it may be that they're on their way to cure. There are always going to be exceptions, a few, but the probability of recurring at that point is much, much lower. But again, I don't want to get ahead of myself because it's still a little early, but I'm hoping that we'll be able in a few years to say that, hey, if you're 6 or 7 years out, you shouldn't have to worry about recurrence, but we can't say that yet.
Sure, thank you. And also, is there any kind of a database coming around that have the specialists with the knowledge of low grade? For instance, my doc in San Antonio just retired this last year, and it's like, what do I do now?
Great question. No, and the answer is no, there's no database. More and more GYN oncologists are becoming educated, and medical oncologists also, although less so, are becoming educated about low-grade serous ovarian cancer, but there aren't that many, honestly, experts. So you'll hear some of the others today in this meeting today and tomorrow. But if you're saying somebody who really is very knowledgeable about low-grade serous ovarian cancer, there just aren't enough doctors right now that are focused on that, unfortunately. But
Better just to come to Houston.
but that's the reason for That's the reason for another opinion sometimes, depending on, particularly if you're being told you need a change in therapy and have anxiety about that. That's a good time to do it. But yeah, it's hard with the rare tumors that enough physicians are going to have the knowledge to really provide optimal care.
Okay, I'm going to try to articulate this quickly. So because you've got so much info on all the things, for someone who started off with borderline,
Yes.
and then, but maybe when they were first diagnosed with borderline had some little bit of microinvasion of low grade, and then later developed low grade, is it just a continuum of disease, or did I always have, or did that person always have low grade? Like I just am still trying to understand in my brain, because when
Well, one factor is how good was the surgery when you had the borderline tumor. So did they do peritoneal biopsies? Did they do cytologies? Did they perform an omentectomy? The omentum is one of the most frequent sites of these implants. So if you have a borderline tumor in the ovary, that's the reason to do this staging of omentectomy, peritoneal. And let's say if maybe you had non-invasive implants, I don't know, but I'm just for discussion. If you have non-invasive implants and you have a borderline tumor, we estimate that your risk of later developing low-grade serous carcinoma is about 20%. It's about 20%. So, if we have a patient we see like that, we always tell them, you need to know your lifetime risk is 20%. And what does that mean in terms of monitoring? That's also not an easy question to answer, though. But we pretty well know that. We used to think it was even higher than 20%. It was maybe 30 or 40%, but I think it's probably as high as 20% lifetime risk. And it's because of those peritoneal implants, not so much the ovary itself.
Thank you.
Hello, Dr. Gershenson. You know me, I've been on this 14 years now. So I went through lots of chemotherapy, and I also started the MEK inhibitor from 2019. Then it stopped working. I used that for 4 years.
Mm-hmm.
Then it stopped working. I'm on the RAMP trial now. So my question to you, the drug resistance problem is, especially for me, every drug I use, it work for a while, then stop working, and I change it to different drugs. So you have anything research going on for drug resistance, especially for targeted therapy? Because I really like targeted therapy. The side effect is much, much less than chemotherapy.
Yes. So unfortunately, most women are going to at some point develop resistance to any regimen or any drug. The good news that counterbalances that somewhat is we have more options now than we have many more options than we used to. But yeah, we don't really understand the mechanism of resistance very well at all. That is an area of research, mainly pretty basic research, and someday I think we'll better understand that. But right now we don't. But it's a fact of life that at some point, most of the time, you do develop resistance. There are what we call extreme responders that I've had, and there's one patient I'm thinking of that was on a MEK inhibitor for 12 years and did very well. So it can be extreme and good, but yeah, unfortunately, resistance does occur most of the time, if I'm understanding your question.
Okay, so if we cannot resolve that, so all the drug, eventually will not work, right?
How do we resolve that?
The problem, the resistance.
Yeah,
problem.
well, we resolve it by understanding better the mechanisms of resistance, which we don't yet. So, but people are working on it. People much smarter than I am.
Thank you.
Hi.
Hi.
So I just turned 30, so I was diagnosed like a year ago at 29. So I feel like on the young end even for low grade, and I don't have like BRCA or any of the genes like associated with cancers, but there does seem to be some sort of vague genetic link on my dad's side of the family. His mom had ovarian cancer in her 30s, and there's some other like women on his side of the family who have had ovarian cancers. So I'm curious about if there's any like ongoing research on like other potential genetic factors, or have there been in the past? And then I have 2 younger sisters, so I'm just curious like how intense I need to be towards them about like knowing the symptoms and things like that.
Yeah. Well, as you know, there are many, many unanswered questions about all that. I don't know if you had any other mutations in your somatic tumor testing, or? That hasn't been completed yet. Okay, well, that might be important. You know, there is a thought out there that everybody, all humans, should have genetic testing to know if they're at risk for cardiovascular disease or breast cancer or 1,000 different diseases, that we should all just routinely do it. Now, that's not happening now, although some people are doing it, that they're completely healthy, but they want to see what their genetic testing shows at least. But yeah, I think maybe the tumor testing might give some clues sometimes. So I would see what that shows. But yeah, many unanswered questions about that we don't understand. Did you get your question answered? Okay.
Hi. So since the beginning, I was diagnosed a year ago. I've struggled with the pleural effusion, and chemo did not dry it up. It's still there. I had full surgery and everything, and like it's kind of just in the CT it says mild, and I can kind of feel it. Originally, when I was diagnosed, they said that it was cancerous in the fluid, but that was a year ago. So I'm just wondering, like, what are your opinions on treatment for the pleural effusion? I have had it drained like 6 times.
You've had it drained 6 times?
Mm-hmm.
Yeah, thoracentesis. Well, if it's very mild and small, sometimes we don't do anything about it at all.
Okay.
If it's larger, then yeah, thoracentesis. And unfortunately, if you can sclerose it. I don't know, if that was discussed with you at all, that you can put foreign substance into the pleural cavity to make the lung and the pleura stick together and prevent the reaccumulation of the pleural effusion. There are some drugs, I didn't talk much today, but bevacizumab or Avastin is a drug that many times can treat effusions, not always.
I was on that, and it didn't help at all.
Yeah, but did they recommend sclerosis at all?
She said she didn't want to do something like that, like for the risk of infection.
Yeah.
And she said to just kind of watch it, and if it really bothers me, to do something. So I don't know if you'd recommend, like, should I get the fluid tested again to see if it is still cancerous?
Are you still requiring thoracenteses?
I'm not. I mean, I can feel it when I breathe in, but like it's not as bad as it was.
Yeah, if you're not, then it means it's probably small and they're probably kind of ignoring it, would be my guess. And I wouldn't necessarily worry about that too much.
Okay. I mean, that's what my doctor said too, so thank you.
So You mentioned implants, and I had a question about that. What exactly are implants? Are they pieces of the original tumor? Are they spontaneous growths? And what are the differences? Why do some women have like large tumors and other people have like scattered small tumors all over? Just what exactly?
It just shows you the variety of kinds of distributions you can get. Yeah. So yeah, some people have either even microscopic implants that you only find when you, for instance, remove the omentum. Some people have 1 or 2 centimeter implants, maybe if it's, or 5 millimeter implants that you can see when you operate, but don't show up on imaging at all. And then other women may have very large masses. We don't, if you're asking me why is that, we don't really know yet why there's such a difference. Maybe it's just time that somebody was, if they'd been diagnosed much earlier, they would have smaller burden of disease.
So are the implants, are they cancer, or can they turn into cancer? Or?
Well, the implants, yeah, usually they're cancer, but yes. Okay. But again, when I talked about borderline tumors, serous borderline tumors, you can have these what we call non-invasive implants, which are essentially borderline implants that are not cancerous, but they are maybe precancerous, if that. So implant is just simply a term for, usually it denotes a smaller mass of cells that can be malignant or not. Maybe they're not malignant. Implant doesn't tell you if it's malignant or not. And it's just another term for a small mass.
What are your thoughts on IGF-1 playing a factor with low grade? Or do you have
My thoughts on what?
the insulin-like growth factor?
Okay.
With low grade? I've just read studies on that.
Well, Dr. Wong's here. He may want to comment on that when he talks.
Okay.
Yeah, I think he did some preclinical studies, if I'm recalling correctly, that showed that there may be, we actually tried to get a drug company interested in a drug along those lines. Mm-hmm. Again, they weren't interested. But yeah, there may be something there.
Okay.
That needs to be further studied.
Further studied?
Yes.
And then for HRD testing, if like they came back and said that there was not enough tumor tissue or whatever when we sent it in to be tested, is that something you would recommend us going back to?
You say HIV testing?
HRD.
HRD.
Sorry.
Yes. Okay. Sorry. Yes. Yeah. Definitely. We always recommend HRD testing. Now that's much more applicable for women with high-grade serous.
Okay.
Because if it's positive, let's say they get genetic testing, they don't have a BRCA mutation, but if they're HRD positive, they are candidates to have a PARP inhibitor once they finish their primary chemotherapy. HRD positivity in low-grade serous carcinoma is quite rare.
Okay.
But yeah, it usually gets tested as well, though.
Okay. So if it came back as not doable, we should have it redone, basically, because she didn't have any mutations. She didn't.
Not
have
particularly.
anything,
Yeah, I wouldn't necessarily. If it came back negative, I wouldn't necessarily redo it. If that's your question.
It didn't come back.
Oh, it didn't?
Well, it said not sufficient enough.
Oh,
tumor,
okay.
basically.
Yeah, and this is somebody with low-grade serous carcinoma?
Yeah.
Yeah.
And she didn't have any
Yeah,
mutations.
it probably wouldn't be a bad idea to retest it, but it's very likely to be negative.
Okay.
Yes. Hello. Many trials require you to have a line of chemotherapy before you can be in them. With so many women going straight to Letrozole or an AI,
Yes.
is that going to be changing?
We're trying to change it. I'm actually surprised that the RAMP study requires it, because we've been discussing this. We discussed it in our International Consensus Conference in 2022, and we all agreed that's crazy to require that. But I don't know why they did. But yeah, I think it shouldn't be a requirement. That's my personal opinion, but these trials get designed by committees, and you never know what's going to come out of it. But Yeah, I agree with you, though. It shouldn't be a requirement. And I think at some point it won't be in future trials.
All right. Well, wow. What do we say to Dr. Gershenson?
Okay.